Okay, so healthcare intelligence pitch. Come for the insight, stay for the chat. That's the whole premise of what we're doing here. So, welcome back for all the viewers that are new, or obviously for the viewers that are coming back. And our viewership has gone, skyrocketed, which is obviously super super exciting for us. This is meant to be an informative chat for everyone that's going to come in that might be new to supply chain, finance, etc., and really have a unobstructed view from leaders in the healthcare industry sector. So every episode begins and starts from a genuine place of passion. We're very energetic about what we do, and then if you spend enough time in media and working for your own organization, typically everything that people see is scripted, softened, let's say might even have a bit of a legal framework, or completely restricted. We never get to see the real view of individuals. So the whole point of what we're trying to do here is provide something very different for the audience. Guys, is this the first time that you've met?
Yes. Well, we've met at conference before.
Yeah, but you didn't know who was actually going to step into the room.
We had
That's
no
correct.
idea.
Yeah. So, surprise.
Surprise, yeah. So no, for the existing viewers, this is not Luis Ferreira from from Christiana Care. It's Bill Kapitke. Okay, and I'll go into a little bit more there. So we've actually built a space with everyone trying to actually understand the points of view. Sometimes what we actually want to try and position isn't a political point of view. It's not a business point of view. It is really an editorial lens of what we actually want to explore. Editorial from a viewpoint that this isn't going to be a library of this is the best way to actually look at things, or the best way to a use case for you to actually consider. It's just really, what did you think about this, and how do we actually get into that, right? And through your thinking. So that's what I'll be probing. Okay. So let's get into it. Today's topic, and you don't know what the topic is.
Something with grapes and wine themes.
Something with grapes and wine. Okay. So I'll allow you to actually just try and think about it. But, whether you sit in finance, supply chain, or in the C-suite, if you work in healthcare, you work with GPOs. All those veins are popping. Yeah, I don't know. You see that emoji with regards to when a person comes up, and then all of a sudden the brain just pops. Okay, so you might have been selected for one reason. Okay, you sign contracts through them, you buy through them, you measure your savings through them, and for most organizations, this is the word that I love. They are the invisible architecture of how money moves. I'll let you reflect upon that. Okay. So, invisible architecture of how money moves. And yet, very few people ever seriously question, is the architecture sound? So the problem statement that we're going to actually be talking about, and what this makes us compelling, is that we have two guests today. One, Bill Kapitke, and Bill has actually spent a number of years in Vizient prior to, let's say, the role that he's actually assumed in Amazon for 9 years, and now has just moved out into a manager in waiting, or an executive in waiting, for a new venture, or from a venture fund perspective, or VC fund. And so when we talk about your background, moving from healthcare into, let's say, healthcare technology, it is a completely different lens that not many people have actually got, right? Moving from the GPO, advisory, consulting, purchase services, now into healthcare, health technology, and obviously a very successful business that you actually ran with regards to Amazon. 4 billion, I think, in revenue as well. So, Jeremy Strong, there you go. Many of the viewers would actually know, but for those that are new, Chief Supply Chain Officer for Rush, a very distinguished individual. Once again, a different sort of lens on the business. Comes from the OR side of the business, and then for the last 7 years, represented with regards to supply chain. So, when we actually talk about this, then, there's two very different vantage points. One from Bill, and then one from Jeremy. We're going to apply the same lens and format. We're going to have 7 minutes where we'll just talk about the topic in general, and I've got some questions, and then you'll break away into your separate rooms, and then I will be asking, let's say, similar questions to the individual. We've based it on the Rugby Sevens format, so every 7 minutes, a new question will actually come in, and you've got 7 minutes to actually answer it, and I'll be just doing a little bit of probing. Then the next person comes in, and then we roll out. Okay, here we go. 3 GPOs manage approximately 300 billion in annual spend volume. Around 97% of all US hospitals operate under some form of GPO contract. So 2 structural problems define the model. 1, the business model conflict of interest. GPOs are primarily financed by manufacturers through administration fees, averaging 3% of contract value. There is no structural incentive to negotiate a better price. You might have a question about that. Okay. Second structural problem is data transparency, no last mile control. Product identity mismatches and the absence of transaction level verification creates significant price variation. According to McKinsey, the clinical procurement study in 2025, prices paid by different health systems for identical items from the same manufacturer can actually vary by as much as 100%. So this raises a direct accountability question. The Health Supply Chain Association claims GPOs generate 55 billion in annual savings. That's a big number. Big number. The question is, who can actually validate this, and why is there no independent data that exists? The only federal assessment of GPO pricing effectiveness was conducted by the Government Accountability Office in 2002, long time ago, by request of Congress, and the insights speak for themselves. So this is a direct quote from this particular study. I would have liked more recent, but there's not. The extract reads, for some pacemaker models, hospitals using GPO contracts got considerably better prices, up to 26% lower. But for other models, prices were up to 39% higher than hospitals not using a GPO contract. For pacemakers, a large GPO contract infrequently yielded better prices than smaller GPO contracts for only 5 of the 18 pacemakers compared. Okay. So, now we get into the questions. So, my verbiage is done. Now I'm going to hand it over to you guys. Question 1 for the next 7 minutes. Are you actually saving 18.3% just partnering with a GPO? So Jeremy, question is, as an operational leader, do any of these numbers reflect what you actually see on the ground? And can you really point to a specific moment where these structural problems became real for you?
Wow, that's a big question.
It is a big
Yeah,
question.
So I guess I would describe it this way. I don't view GPOs as purely like my savings, like umbrella, right? It's a piece of it, belonging to it for a couple different reasons. But yes, I use it as, I call it the backstop, things I don't have time to get to, my team doesn't have time to get to.
So you're blind with regards to think, oh, I'm just going to...
Not blind, but things, a lot of commodity stuff that's...
You'd assume.
Yeah, you assume that but then a lot of the higher cost stuff, I won't use it for. It's basically we're going to contract for that ourselves. So it's part of a strategy, but it isn't I don't rely on a GPO for my savings opportunities, essentially. I'm tackling those. They're more of a floor. Basically, I don't want to go below that, right? I want to try to improve things as I can. So that's the way we look at it at Rush. It's basically the floor, right? So, and then what was the second part of your question? Like,
just really, can you give us, any anecdotal sort of evidence, or not evidence, around what you've seen?
As far as
structural problems where...
Yeah, the structural problem question. I do think because GPOs are beholden, and this is all of them, right? Like, I think they are a bit beholden to the manufacturer vendor base. There's an element of, I think they don't push as far as they could if they were more independent on things like holding vendors accountable to contractual terms, as far as not just pricing, more of like performance, fill rates, things like that they have to, you can sense them being careful around those issues, right, of pushing vendors too far because...
Really? You can sense it?
Yeah, you can. You can, because you can tell that they're willing to go so far, but they're playing a balance. You can sense the balance between health systems or their customer, but then they also have a customer that's the vendor base, right? They're two customers they're catering to, and there is a...
But the most important person, right, is the patient affordability.
Agreed. But there is that, you sense it in that, why don't we hold them more accountable on things? That's where you sense some of those things come up.
Okay. And Bill, from where you're sat, do these problems resonate? Or does the picture look different because you've been on the GPO side?
Yeah, I think this has long been a controversial topic. It's not new. I think it's behind the scenes that sometimes it gets very animated where people get pretty fired up about it, but it doesn't come out in public as much. So I guess to your topic here, congrats, because it can be one that needs more public attention, I think.
It's either that or it's a commercial suicide.
Yeah, no, this is a clickbait for sure here. So, more than ever, health systems need to know how they're tracking to real savings and value. And I'll say that nobody really believes, I say nobody, I'm being dramatic. There's a lot of kind of a grain of salt when you look at the GPO reported savings. Like, what are we benchmarking against? Is this a retail price? Because nobody's paying a retail listed price. Having to account for the back end fees of administrative fees and all the carryovers with rebates, it gets very confusing to know, wait a minute, what would I have gotten to market? What did I actually save? And so, no, I don't think that CFOs are confused, or I don't think that they're convinced that that's actual value that exists. And then to the second part of your question, I do think that there is an inherent conflict of interest. And, that can be very pointed to say. But if you just take the simple lens of your customer is who pays you, well, GPOs are paid by suppliers. They also hold back money in order to give it, for what they're giving back to providers. But it's not clean cut by any means, the relationship and being only provider aligned. And it takes the entire ecosystem to pull it off. But if a major value proposition of the GPOs is cost savings, there is an inherent conflict of interest, and people just don't talk about that.
So I love talking to you at the moment, Bill, because I can just see actually if you're just listening on a podcast, you won't see that Bill is actually going red and his veins are popping out of his head, and that he's I think it's a very passionate sort of view.
It is, and it's not a new topic to me. This gets pulled up behind the scenes in pretty high emotion.
I think this is fantastic. Yeah. Okay, question number 2.
Okay.
95% of US hospitals operate under a GPO contract. The level of market penetration usually signals either exceptional value or the absence of a credible alternative? In your view, which one is it? Jeremy.
Well, you made me go first.
Yeah. Well, you're furthest away, and I'm really getting into Bill later, so don't worry.
So a credible alternative to the GPO. Why
Or exceptional value. Which one is it?
I would say I wouldn't put it in exceptional value. I would put it more in. I think it's more of the time. I really think it goes back to my first answer, which is health systems don't have time to tackle everything. So it's enough value for them to kind of create a floor. A lot of the bigger systems to create a floor for some things on some of those contracts where you see 90% compliance. And I also think the other side of that is certain manufacturers will say, I only work through GPO contracts and force health systems into doing that. So
Wow, that in itself is a
then
problem.
when you have that, you know you're not getting the most value. So
Yeah.
Yep.
Well, that to me is a structural.
yeah, that would be part of that structural
discussion.
challenge. Yes.
Yeah. And Bill.
Yeah, I'm gonna cheat a little bit and say both. You know, I don't see the GPOs going away. I see that there's a clear value, just whether it's the contracting process or the collaboratives that you're able to be having, the insights that they bring forward on products and the supplier community. So, you know, that there is this want to have it, to have a GPO relationship, and there's also the want to have even more than has come out from how these have evolved, because the industry is consolidated to a pretty high degree that it doesn't feel as competitive as it used to be. And I think you've got some mid-sized GPOs that have tried to come in and provide some unique value, but just haven't been able to compete at scale. And I hear from health system customers that they wish there was more innovation, that they wish there was more sweating to the same margins that providers are being held to. So there is value, at the same time, exceptional value. I'll agree with Jeremy, that's not quite the case.
Yeah, I would agree.
Yeah.
And there's value isn't just pricing too. There's other aspects that I'm sure we'll get into. But
Yeah, absolutely. So question 3. Big pause here.
am I gonna have to answer it first again?
No. I'm going to give it to Bill, because otherwise you can actually just say, oh, Bill, I'll go 50-50. Okay, none of us 50-50 stuff, right? You got to say yes or no. Okay, question 3. At what point does the GPO model cross from being a procurement efficiency mechanism into a form of market control that limits competition and price transparency? So, as an example, distributor profit margins versus hybrid supplier profit margins and OEM profit margins. I don't know if you've done your research with regards to that, but as an OEM, you're talking about the high 60s to 70s with regards to gross margin. Then when you actually go into hybrid, for example, someone who manufactures as well as distributes, you're talking in the high 20s. When you get to the distributor, you're talking about low single digits. Okay, so, and that to me is quite scary with regards to and then go back to the hospital system. That's either -5, 5, or 1 or 2%. Okay, so question is, at what point does the GPO model cross from being that procurement efficiency mechanism into a form of market control that limits competition and price transparency?
So I think important to keep in mind is there's a lot of different types of spend categories across a health system, and not all are beholden to, if I don't have a GPO relationship, I'm not going to be able to make it within the market. At Amazon, I did not authorize and did not pursue any GPO relationship, and that was intentional to have a more direct relationship, very technology backed, between the buyer and the supplier. And we, Amazon didn't really need an introduction, and so we didn't feel that the value was there. At the same time, unfortunately, there are suppliers that feel like if they don't get the GPO award, they're going to be negatively impacted, even if that's just a hunting license, meaning it's not the best of your pricing or your contract guaranteed. And so, if certain spend categories within MedSurg don't get awarded, are they going to be able to grow effectively? No. Like,
Mm.
yeah.
Okay. Jeremy.
That's a. I'm trying to think of how to answer this question.
That's the whole point.
Yeah.
Don't think.
I think that I don't think there's necessarily. I agree with Bill. Like there is vendors that feel like they have to have it, and I think that's partly because when you think of again a lot of health systems, especially smaller ones, are more reliant on that. So that's your floor, that's your backstop in some of these categories you don't have time to tackle. It is the entry to market to have. If you don't get that business with the GPO, you're going to have a greatly reduced opportunity, right? So I do think that,
Like you say, it's not a given.
Yeah, it's not a given at all. I think that. What was the first part of the question? Like you asked, like.
So is it a procurement efficiency mechanism? So are you using it, to your point around, we don't actually have the resources, we don't actually have the time.
I think that is a huge chunk of, from a health system side, for some of these categories, that is a huge part of why they do find it as inefficient, which is why it leads into, from the manufacturer side, for certain manufacturers, that is their bread and butter. That's how they're going to have to, if you don't get that business. So I do think it creates that dynamic in certain aspects. I also, Billy, you said like there's a lot of categories. Health systems, I mean, it's like 20% of my spend's rolling through a GPO. There's a huge chunk that is not, right? So it isn't an all or nothing kind of game. So, but I think in certain categories, especially some commodities, it is hugely critical, and that dynamic I described exists.
Yep. Okay. Fantastic. So I just wanted to actually give that as the framework with regards to let's say, the next questions that are actually going to come at a one-to-one basis, because that's really the background. We'll explore, over the next time, various questions around the GPO model and such like, but I just wanted to actually just make sure that you can go back into your room, start to think about it, and then come back. So so what we're going to do is first break away. Jeremy, if I can actually ask you to leave the room, that'll be great. And then Bill, I'll start with you with regards to this.
All right.
Sounds good.
Put the headphones on, do your email.